Here we go. All right. So next slide. I will only touch on classification. Then Dr. Palmer has already given you, as have others, an outline, but they are relevant, of course, for transplantation. Go to indication, strategies, and outcome, importantly. Next slide. This is a summary of three of the classification, and many more, but the important point being, dependent upon what the parameters are that put a patient into a particular risk category, I think our decision in regards to transplantation, or at least the timing to transplantation, may vary. Is it based on cell counts? Is it based on cytogenetics and so forth? We'll go into some of that. Next slide. Just to comment, there are a number of factors that are relevant for transplantation, which, however, are not reflected in any one of the classification schemes, particularly pulmonary and portal hypertension, which can indeed lead, particularly if it's far advanced, to significant complications after transplantation. Next slide, or in the context of transplantations. So here are the major indications: marrow failure, of course, increasing transfusion requirements, disease acceleration, leukemic transformation, and as always, the failure of non-transplant modalities. Next slide, please. Here is a summary slide of a recent publication of our data, some 230 patients with primary or secondary myelofibrosis, classified by the DIPS plus with the 8 parameters. And as shown here, if you are low or intermediate, there are very few patients transplanted at that stage, but the outcome is, I think, remarkable. The black line and the blue line, intermediate 2, slightly less good. And once you are far advanced in a higher risk category, the red line, clearly the outcome is very disappointing. Next slide. The interesting part is that it was not so much recurrence of the disease, but rather non-relapse mortality that determined that inferior outcome in advanced patients, presumably because the disease had taken over a number of other organs, particularly pulmonary, hepatic, and so forth. And in the context of transplantation, that became a major problem. Next slide. Age does make a difference, but to emphasize the point that it is mostly related to comorbid conditions, which are more frequent with increasing age. That aside, however, even what we are looking at is looking at a highly selected population of older individuals. So there is clearly a bias in selecting patients. Next slide. However, recent results, and these are all comers up to 70 years of age. It's a small number in this slide that Dr. Salik presented recently from our center. These are patients who did get Ruxolitinib systematically before transplantation for at least 2 months, and then went on to transplantation either from related or unrelated donors. And as you can see, the 2-year survival was slightly in excess of 80%. We have now more than 50 patients on this protocol, and the results remain similar. There is an occasional late failure, and we will come to relapse in a moment. Next slide. Just for comparison, some data that Dr. Gupta presented some time ago, looking at reduced intensity regimens, and which is, of course, a very hot item still after many years of development, where the non-relapse mortality is low in the lower red box, but the incidence of relapse is higher. So there is a trade-off of relapse versus non-relapse mortality using reduced intensity, low intensity, or high intensity regimens. Next slide. This is a more recent, taken from a more recent paper by Dr. Kuykendall in the Annals of Hematology. And what he shows now, okay, these are patients who have also received Ruxolitinib but have progressed, and we're transplanted, as he says here, a salvage procedure. And you can see that for those patients, green line transplantation clearly gives you the best results in comparison to other salvage efforts in red, or a no treatment observations. Of course, as pointed out by others, with new strategies in the non-transplant arena coming along, this may very well change, and there may be sequential treatments before the patient considers transplantation, if the patient considers this at all. Next slide, please. Now, of course, everybody is thinking about mutations. Next slide. And just a couple slides from our own work here that Dr. Stevens presented very recently last year. To cut a long story short, what everybody else has observed as well, it is not so much just one individual mutation that determines the course, but rather the cumulative presence of mutations that determine how a patient is going to do. What is shown here in the red line is only one of 11 patients who had 3 or more mutations became a long-term relapse-free survival. And as the remainder of the group, we look at less than 3 mutations, green line, good outcome, 3 or more. The outcome is, of course, poor, and that is mostly related, but not exclusively, to relapse. So clearly the disease biology is an important factor. Next slide. And this just summarizes those results. Again, 2 or fewer mutations compared to 3 or more mutations. Survival is clearly inferior with a higher rate of mutations related to both non-relapse and relapse mortality. Next slide. This looks complex, but it is a simple slide. Very nice data put together by Dr. Harris from City of Hope. Just basically to make the point that cytogenetics is an important factor here. Favorable cytogenetics in the second panel on the left in red, superior outcome to patients with unfavorable or very high risk cytogenetics. That is not so much reflected in overall survival when we look at high risk mutations. Again, adding a note of caution that certainly mutations by themselves, or any one mutation by itself, should not be a determinant, in my opinion, about in the decision-making process regarding transplantation. And then at the bottom here, including the MIP70 developed in Europe to include mutations into the scoring system. Patients with a favorable score do much better, as you can see in the red line, compared to patients with an unfavorable score. And next slide looks just at a couple individual mutations. If we look at the slides, are not of good quality, but that's the best I could generate. As you can see, if you have a favorable situation as far as the mutational landscape is concerned, then your probability of relapse is low and survival is higher. If you have an unfavorable, then you have a much higher risk of non-relapse mortality as well as relapse that I pointed out already before. Next slide. A Spanish group recently presented a simplified risk score, particularly for transplantation. Next slide. And I, in fact, like that quite a bit. It's very simple, but it makes some sense. So mortality is increased if you have a higher comorbidity score. You get 1 point for it. You also get 1 point if you get an unrelated or cord blood transplant. But you can actually subtract a point if you are receiving cyclophosphamide after transplantation, which has been shown to definitely reduce the incidence of graft versus host disease, this very unwelcome complication of transplantation, particularly in its chronic form. And when adding up those scores, they had a 5-year survival in these patients of almost 80%, with a negative score, not having high comorbidity and having received an HLA-matched donor, survival of 55% if your score total came out as 0, and only 32% if the score was 1 to 2. The previously published data by another European group that incorporated the donor type into the disease categorization did not turn out to discriminate patients in this setting. So, I mean, as I said, I think that needs to be confirmed, but I find that helpful in a very first glance assessment. Next slide, please. And this is the graphic display of those results with a score of -1. As I said, almost 80% survival if you have a higher score. It may go down to 25% long-term survival. Next slide. Now, what is the prognosis of patients who relapse post-transplantation? In fact, one of the people on the call asked this question, at least indirectly. This is, again, a paper published in just recently, a few months ago, looking at 227 patients transplanted over a pretty long interval of 2 decades. Of those, 94 were surviving in complete remission at or 5 or beyond 5 years, and then some of them, 13, relapsed at a median of 7 years after transplantation. They were treated with DLI, meaning donor lymphocyte infusion, to add an additional graft versus leukemia effect, or received a second transplant, as shown here, 4 of them. And of those, in fact, 8, which is 72%, achieved a complete remission, and 7 of these 8 survived more than 3 years after having suffered a relapse. So it is definitely worth looking at that possibility for patients who relapse, although, as we can see, the success is not uniform. Next slide. Now, based also on what we have heard already today in regards to risk factors in the evolution of the disease from very early on or later with sequential assessment, like the IDH1 or 2 mutation, RUNX1, U2AF1, a spliceosome factor, and in the long-term impact mutations in 53, TP53, NRAS, or BCOR. I am just listing them there as conceivably we will see, or pilot studies are ongoing already, that addition of agents, either pre-transplant or post-transplant in high-risk patients who happen to have one of those mutations as an adjuvant therapy, may indeed further improve outcome, particularly by reducing the incidence of relapse. And Dr. Palmer touched on that, as well as did others. Are there mutations that should lead us to an earlier recommendation of transplantation? Maybe there are, but I think we clearly need additional data. And I repeat what I said already a couple of times. I would not recommend a decision based solely on the mutational landscape, although it is, of course, a very important part. Next slide. These are some data by a German group looking now at the outcome of transplantation after leukemic transformation has occurred, unfortunately. And there has been a somewhat nihilistic approach to that until very recently, because data were not good. What these data by Dr. Ashalbi show, however, if you can induce a remission pre-transplant by chemotherapy, and maybe in the future by other means, cellular therapy, for example, then the outcome is in fact not that bad, with a survival in this group, small group of patients, in the range of about 70%. But it is, of course, only a proportion of patients who do achieve such a remission, and the remaining patients do very poorly. Next slide. So just a few more thoughts on the genetics and treatment options. We have heard about JAK2, triple negative, calreticulin positive. All those are factors that impact it. There is this well-defined by now JAK46/1 germline variant, which may deserve additional attention in our treatment decision. And certainly, as I mentioned already, targeting other genes such as ATM1, SH3, another spliceosome factor And new non-coding regions that have been identified may serve as targets for adjuvant therapy. Clonal hematopoiesis of indeterminate relevance or prognosis increase with age. So we know that there's nothing we can do about it if we want to survive. We get older, but I think we will see, and a couple centers have started to do that already, to monitor patients for their clonal hematopoiesis earlier in the course, trying to determine whether that could aid in the decision-making process. And there's certainly a lot of work going on inflammation. Would suppression of inflammation improve the prognosis? And as I said now a couple of times, that recognition of those potential targets could very well lead to preemptive or adjuvant therapy, both pre and post-transplant. Next slide, please. So a very brief summary: transplantation does cure many patients with MF, but it does not guarantee a cure. There is a relapse rate, maybe in the range of 10 to 15%. Both with high intensity or reduced intensity regimens. There's a trade-off, as I pointed out, between relapse and non-relapse mortality. Outcome is superior and earlier, lower grade disease, as Dr. Palmer pointed already out, in the absence of multiple high-risk mutation, in the absence of comorbidities, and with the use of post-transplant cyclophosphamide or Cytoxan. Salvage is possible in a proportion of patients after post-transplant relapse. The next slide. Just thank you to a few individuals who have contributed, made major contributions, both in the lab and clinically. And final slide, but to do all that, it certainly takes a big team. This was taken a few years ago at our center. Thank you for your attention.